Welcome to those who are joining. We'll get started in a couple minutes. Thank you, though, for those who are signing in. We will start in a minute or two. All right, we will get started in about 1 minute. Okay, let's get started. So welcome everybody for joining us. This is our ICSI webinar on reducing agitation in the ED. How can we approach it differently? So we're really excited to share this work with you today. And just want to take a moment to pause and let you read this graphic. So I will just reflect that things are difficult now. There is so much going on in the state, in the world with COVID and so many other things that we all have our moments. And I think just being there for each other is so important. That's what this agitation work was also about, just being there for our patients and for each other. So this really resonated with me and I wanted to share it with you all. Okay, now let's get to the presentation. So for the next 30 to 45 minutes, we'll just be sharing the work that the ICSI work group did around agitation. And I'm really excited today to have Laura and Lou here with us. They were two of our work group members. Really, their insights helped shape the work. So I'm going to have them do quick introductions if that's okay. Laura, can I start with you?
Certainly. My name is Laura Kitch. I'm a clinical nurse specialist in Duluth, Minnesota at Essentia Health. I have 20 years of experience in the emergency department working with patients who've been agitated, mental health patients, and ED patients who can certainly change in their demeanors and presentations and agitation levels when they are in our departments.
Thank you, Laura. Welcome. Lou?
Thank you. I'm Lou Zeidner. I'm the System Director for Clinical Triage and Transition Services at mHealth Fairview. And one of the initiatives that we've been working on diligently is the start of the empath unit, which is really an attempt to engage patients in different ways and reduce their agitation more effectively.
Terrific. Thank you, Lou. We're excited to have you both join us. And Laura and Lou will kind of speak throughout the presentation, adding insights from their organizations, lessons they've learned, both good and both bad, to help us kind of move forward as a state. And so a little background on the work and where we started. In 2018, mental health and emergency department leaders from around the state came together with us at ICSI as part of our Minnesota Health Collaborative initiatives. It was an initiative around mental health and around opioids. And the team kind of identified that even though like there was really good practices for cardiac distress or stroke, really good algorithms and protocols, there wasn't great evidence or protocols around mental health issues. And so they chose 3 areas of focus: suicide prevention and intervention, prevention and management of agitation, and medical clearance evaluation. And so together there were 3 bodies of work, and we put this together in one package that's now out on our website, and we have shared standards around the 3. You can go to the ICSI website. This is just a quick graphic to show you how to get there, and click our mental health tab, and we'll take you to the standards for all of these. Today's focus is the agitation, but there's also great information on suicide and medical clearance as well. And we do have an upcoming webinar on suicide prevention that will be in September. We will advertise that later on, but Wednesday, September 29th at lunchtime, save the date. That will be a really great presentation. So let's just get into it with agitation. Oh, and I don't think I introduced myself. So I am Jody Dvorkin. I'm the facilitator today, and I am the medical director at ICSI. So thanks for joining. And what I will do is kind of present some of the work from our standards document, and then Lou and Laura will kind of add in their insights as we go along. Please feel free to use the Q&A, ask questions, and we're happy to answer them throughout the presentation, or if we can't get to it at the end of the presentation. So just to level set, agitation in patients in emergency departments is becoming more prevalent, with about 1.7 million episodes annually in the US. Agitation is a symptom, whether of mental illness, substance misuse, past trauma, or something else. So it is important to properly assess it and understand what we can do to mitigate it or actually, we feel, prevent it. So our goal with this work was to shift the current thinking and practices around agitation from a reactive approach to, what do we do, call in the team, this person's agitated, to really creating an environment that was proactive and prevented agitation or escalated agitation from occurring. Really focusing on a therapeutic environment. And this is important not only to support people experiencing agitation, but it's also critical in caring for the staff that takes care of these patients. So this is the framework that we developed, and this is what we're going to present today, and we'll break it apart. But essentially, we have our initial assessment of the patient, and this is before they get to the ED department. So this is out in the field with the paramedics, EMTs assessing, and then bringing the patients to the ED and really emphasizing the need for warm handoffs. And then once they're in the emergency department, we have 3 zones: The green is prevention for the non-agitated person. The yellow is prevention of escalation for the agitated person. So the patient is agitated but can be treated by the care team. And the red zone is management of escalated agitation. The agitation is escalating and additional resources are needed. And so we'll walk you through those three zones. The hope is to kind of stay in the green or yellow zone, and that's the goal of the work. But we recognize some patients will need to be in the red zone. And then disposition, how do you get patients to the appropriate level care, and how do you kind of hand them off appropriately? So I'm going to start off with the initial assessment, the warm handoff. So the heads up from law enforcement in the ambulance prior to arrival from the to the ED. Suggested questions, I'm not going to read them all, but just highlight a few. So what was the reason for the call and who made it? Are there suicidal concerns or threats? Are there concerns for substance use or overdose? Is the patient cooperative, or did they need to give any medications or place them on restraints? Other medical conditions? Where was the patient picked up? Was it at home or somewhere else? And are there any witnesses for collateral contact information? So all of these are important to really creating the story to understand what situation the patient is coming from. And then on arrival to the ED, it is important to evaluate the patient to determine if they are currently agitated, at risk for agitation, and are at risk for aggressive behavior. And there are tools to do that. We have that in our document, so I encourage you to look at that. We're going to focus less on the tools and more on the concepts today in this webinar. I'm going to pause and ask Laura to comment on initial assessment, thoughts that she's had or experiences that they have found useful.
So one of the key pieces for this portion of the evaluation of this patient that's presenting is, having that background from the either EMS or law enforcement that brought that patient in, and just, having the background so that the team can be prepared for what they're going to encounter, making sure that they have the appropriate team members there. One of the pieces that we implemented here is, and it's in the tool that Jody had mentioned before, is assessing the patient using bars, and just really being prepared and knowing how to intervene when that patient arrives. Also preparation of that staff ahead of time, training for the staff so that they're able to have the tools that they need to de-escalate patients that they need. And just really being prepared is that important step for the initial assessment of this patient.
Thanks, Laura. Lou, I'm going to turn it over to you.
Thank you. I think one of the issues that often happens in these situations is we see the agitation as purely within the patient, and it has nothing to do with where they are, how they're treated. And what we've found is that a lot of the work around the environment, around the people engaging that patient, very much can change the level of agitation. And so certainly sometimes agitation is a symptom of an internal pathology, but oftentimes it's a function, a response to a set of environmental events. And as you talked about, oftentimes first responders, police officers, others have a certain amount of difficulties with that patient, which increases their agitation as they're coming in. So certainly preparation is there, but also environment that can be calming is less rule-driven and more about helping that person to reduce their agitation.
Great, thanks, Lou. So that takes us into our green zone. And I have to say, I think that this is the most important zone in our document because this is probably the area that was most overlooked prior to us doing this work. This was the prevention part of not getting agitation, not getting the patient agitated versus dealing with agitation once it's occurred. And so there's a few areas we wanted to focus on. The first is engagement. So really practicing trauma-informed care, having your providers trained in trauma-informed care, and important cultural considerations that they need to be thinking about. So our document will go into length about resources for this, but this is really important in terms of that first interaction with the patient, how to make them feel comfortable, and continuing then to do so throughout the visit. Environment. We encourage the least restrictive environment. offering food and beverages when appropriate, recognizing people can be in the ED for very long times. Empath units, and we'll talk about that in a second, are really a great concept that really aims to create that therapeutic environment. Home medications. So delaying or not giving regular medications may lead to agitation. So it really could be an iatrogenic thing that the patient's in the ED doing just fine, but they never got their meds. So that's why they became agitated. So not forgetting about home medications. Safety precautions. So this may include separate rooms, scrubs, or a sitter, depending. You have to think about the safety of the patient or of other patients and the safety of the staff. So safety precautions shouldn't generally be needed in the green zone. I mean, these patients are not agitated, but depending on the history or the story, and this links to the initial assessment of why they came in, certainly some of those could be implemented if it's felt to be necessary. And then monitoring for agitation. So monitor clinically throughout the ED stay. Just because they come in initially not agitated doesn't mean that won't change over time. And as Laura mentioned, the bars is one good tool to kind of continue to monitor throughout the ED stay. So we think together these things kind of help keep people in the green zone, or at least it's a step in the right direction of being thoughtful and having a systematic approach to these patients. Lou, I'm going to start with you this time. Comments on any of these areas?
Thanks. Well, I think one of them is that emergency departments are typically designed around trauma care, around cardiac care, around other non-mental health care. And so they're designed to be fast-paced. They're designed to be loud and efficient. They're designed to control the environment. And all of those things are great for 99% of the patients, or maybe 80-something% of the patients, and aren't especially effective for those who are struggling with mental disorder or some type of intoxication. And so what we have found is that changing that environment, and the empath unit seeks to do that as a department within the emergency department, to have it be a more calming atmosphere, quieter, softer lighting, softer sounds, less fast-paced, and allow for more agency for the patient themselves. So while we need to be safe and make sure that anything they're carrying that's dangerous is identified, can they return to their street clothes? Can they have some abilities to walk around and get snacks? All of those things help to reduce the level of agitation that they're feeling, and therefore some of their aggression. I think just one last element that I would add is that we often slip into the word violence as opposed to the word aggression. And violence has a volitional quality to it. There's even the World Health Organization's definition of violence includes the word intentional. And I think for many of these patients, their aggressiveness around their agitation is far from volitional. And oftentimes we use that as a way of distancing from them. So just a few of the elements that we found to be useful in keeping people calm and reducing agitation and aggression.
Thanks, Lou. And if anybody has experience with empath units, please chat it in. We'd love to hear. And Laura, I'm going to turn it over to you.
Right. So one of the pieces that we've included here with some education initially, actually quite a few years ago, with our staff is to look internally, internalize how are you feeling about the situation if the patient is agitated? How, are there biases that you've developed as you approach the patient, and just really being aware and being present with that patient. It keeps yourself safe, but it also will help you with your interventions with your patient. As far as home medications, we found that to be very important, particularly in our areas. We do end up boarding some of our patients in the emergency department. And we've have worked really hard with our behavioral health nursing staff, emergency staff, to be proactive, find out what those medications are that patient was on at home, and really get them going so that we're able to be proactive and preventing any agitation. Also using that bars to evaluate that patient's level of agitation. Are they increasing? Do we need to start getting PRN medications in place? And then we also have in place the set for our boarding patients. So we're looking at a 24-hour predictor on is that patient potential, do they have a potential for becoming violent or having, if they're agitated, increasing that agitation. So those are some of the things that we put in place here in Duluth.
Great, thanks, Laura. So now we're going to shift to the yellow zone. So sometimes a patient is not going to stay in green, and that we know is not necessarily because of a lack of doing any of those interventions, but just the nature of what happens sometimes, and that's okay. So we have the yellow zone, which is prevention of escalation for an agitated person. So this patient is agitated, either they came in agitated or they became agitated during their stay, and we believe can be treated by the care team in the ED. So similarly, we have safety precautions, assess and manage the underlying etiology, verbal and nonverbal escalation, and pharmacologic intervention is needed. So we're just going to break each of these down just a tad more, starting with safety precautions. So first, there's patient considerations, and we talked about in the green zone, although this is a little bit less relevant there, is kind of more the exception. And I'd say that has to be considered every time in the yellow zone. Decide whether the patient needs to be changed into hospital scrubs or whatever standard clothing your organization uses, and whether they need a sitter. And this is important to refer to organizational policies and regulatory requirements when deciding this. Physical environment considerations have easily accessible alarm systems, doors that open outward, cannot be locked from the inside, allow easy access from the outside in case of an emergency, barrier-resistant doors, location close to staff areas, and unobstructed viewing windows. So that's safety precautions. I'm going to pause at safety precautions. And Laura, just any of your experiences with this, what's worked well or what's maybe given you guys some trouble?
We have implemented a few pieces here. We did have doors that opened inward initially. So we did have some situations where safety was a concern. So we've now transitioned our doors so that they swing both ways in case of an emergency. Some of the other pieces that we've implemented is to really train staff to be aware of their environment, that situational awareness, what's in the room when you're entering the room, getting them, if the patient is becoming increasingly agitated, then do they, make sure that they have an escape from that room. So really awareness of that staff, as well as something else that we've put in place.
Thanks, Laura. Lou?
So what's interesting is we opened the empath unit in March, early April, and we've treated about 900 patients who've come through there, and we have yet to have a need for any physical restraint or seclusion of any of those patients. There have been a couple who've been certainly agitated, pushing furniture around, raising their voices, but we've been able to de-escalate virtually all of them with verbal interaction. And part of that, I think, starts with an expectation of the staff that they can, an expectation that we're going to be successful with this. Some mental health training is certainly useful. All of our staff in the empath are mental health professionals. But just being able to use the environment, reduce the rules that the patient needs to follow, and having a calming atmosphere has really been able to reduce the level of agitation that we see, and certainly the higher level interventions that we'll talk about in red.
Thanks, Lou. We're going to move on to underlying etiologies. So the patient should be assessed for underlying medical and psychiatric conditions that may cause or contribute to the agitation. And labs and imaging should be based on clinical judgment. And so this segues very nicely with the medical clearance work. So I encourage everybody to look at that document as well, where we really try to focus on tailored labs and imaging, what's needed for that patient versus this is what we routinely get on all agitated patients or all patients who come in with a mental health complaint. So really want to be tailored and do what's needed. Here's a graph. We don't really need to talk too much about it, but differential diagnosis, underlying agitation, so medical issues, psychiatric and intoxication, all things to think about and rule out, again, as needed, depending on the patient's situation and the patient's story. I'm going to pause here. Lou and Laura, anything to add? Laura, I'll start with you.
I think this is a very important one, and especially in the ED, when we don't know what the differential diagnosis is frequently for that patient who comes in. So really being aware, and again, listening to the individuals that brought the patient in. Did law enforcement see different things in the environment? Looking at that patient's history, what type of underlying conditions do they have that may be contributing to their current state? It's just really important to look at all of the aspects when you're trying to help a patient through these situations.
Thanks, Laura. Lou?
Oftentimes people will say, well, why did you set the empath unit up as part of the emergency department? Why not have a separate door for the empath and not have everyone go through the emergency department at the medical side? And I think this is exactly the why, because anyone coming through the front door needs to be clearly assessed for anything that's going on for them medically, in terms of their intoxications, et cetera. And then when those have been ruled out, when we understand that this is likely a behavioral or mental health problem, then to focus there. But I think jumping to that has certainly caused death for many.
Thank you. Verbal and nonverbal de-escalation. So verbal de-escalation is a method to calm the agitated patient and gain cooperation and trust, so that you can evaluate and treat the agitation. So the goal here is to reduce medication, to reduce seclusion, or a lot of those safety measures, and to avoid restraints. Nonverbal de-escalation includes interpersonal skills, right? Nonverbal cues in the physical environment that really contribute to a therapeutic environment and hopefully help de-escalate the situation. There's a lot of details in our document about ways that verbal de-escalation and nonverbal de-escalation are used. So we just wanted to give you this quick preview, but certainly please go there for good tips and things to think about as you're kind of setting up what you do in your EDs. Laura, any comments here?
We've done a lot of work as far as educating our staff in their approach to de-escalation, and again, just being aware of where they're coming at when they're presenting to these situations, and really being aware of the patient situation, the trauma-informed care approach, looking at who develops a rapport with that patient and who can really communicate and connect with that patient and help that patient through, and perhaps verbally de-escalate the patient versus the escalation and the need for restraints and seclusion.
Thank you, Lou.
I think it's important to understand that most of these patients, the day before their crisis, the day before they show up in the emergency department, were living independently, were living with all the rights that come with being an adult in society. And suddenly they enter the emergency department and they have none of those rights. And many of those rights go away because they need to be in the clothes we prescribe. They need to follow the rules we dictate. If they want a glass of water, they need to push a call button. All of those things further deteriorate their sense of agency. And I think there are a lot of things we can do in terms of how we set up rules and how we set up the environment in which they experience themselves to help de-escalate the crisis and also help them more quickly return to where they were pre-crisis or whatever triggered that crisis for this particular day.
Thanks, Lou. And then I'm going to touch on pharmacologic intervention. So preferably non-pharmacologic approaches such as verbal and nonverbal de-escalation should be attempted before medications are administered. Patients should be engaged in the process of determining the kind of mode of medication delivery. If the patient is cooperative, then we prefer oral medications. And then for really more details on medications, I encourage you to look at the Project Beta recommendations. So they're very thorough and extensive, and that's a really good resource for medications for these situations for the agitated patient. Implementation of these may be facility and situation dependent, and organizations need flexibility into how to implement them. So this might not be a one size fits all, but Project Beta is a really good resource to look at. And I'm sure a lot of organizations are already using their recommendations. All right, I'm going to move to the red zone. We hope not to get here, but we recognize that there are cases that we will. And so things to think about, safety precautions, very similar to the yellow zone. I think the biggest difference here is that the ED may need an additional support. Often this comes in the form of a co-team where additional staff from the ED or elsewhere in the hospital come to assist. So it's essentially more people are needed because now we are managing escalated agitation, and it has really gotten where more resources are needed. Still need to use, still need to look at the underlying etiology. So same graph as we showed, tables we showed you earlier, but I will note that this might need to be repeated throughout the stay, right? So things might change. And so these assessments can be ongoing depending on how long the patient is there. Verbal and non-verbal de-escalation, same techniques as we talked about with the yellow zone and that you can read through the document, still need to be done in the red zone. So the red zone is not very much different, except things are just kind of amped up a bit and more resources are needed to do all of these things. Pharmacologic intervention is an option here and will often have to be used. And then restraints is a last resort. And so there's a lot of guidance around restraints as well. And Project Beta gives guidance. The Joint Commission has some guidance. So important to look at those when you're figuring out how to use restraints for a patient. We hope things never get there. That's really something we want to avoid, but sometimes that does happen. So Lou, I'm going to start with you. Comments on any of these categories in the red zone?
One thing I would just
Wait. Lou.
I'm sorry.
No, that was me. Thank you.
I was saying each of our systems or many of our systems have been spending an increased amount of time looking at the way we balance diversity and equity in terms of the care that we provide. And one of the things that I'm very conscious of is that we have a risk of seeing the red zone more with some people than other people. And we need to be very thoughtful about how we set up standards to ensure that there's not a diversity of response based on ethnic groups or cultural groups or race, other issues. I spoke earlier about the use of the word violence as opposed to aggression, and being able to separate those two and look at the ways in which we use words in these different situations. So again, red is a pretty significant step, and we need to make sure that we're not contributing in an undesirable way to the agitation that's taking place.
Thank you, Lou. Laura?
One of the pieces that we have implemented for situations in the red zone are a behavioral emergency response team. It's actually facility-wide, but we do also have them respond, a similar response down in the emergency department. Some of the pieces that we put in place with that was we actually put a comfort kit in place so that maybe there are some non-pharmacological interventions that we can put in place. When you hit the red zone where the patient's very escalated, then certainly those interventions would not be helpful, but really getting that team with the training that they need. They have all had specialized training. We have security team members, our behavioral health techs, and our nurses who all respond to these situations.
Thanks, Laura. So that takes us to disposition. So determining the appropriate level of care for a patient. So determine which patients are appropriate for inpatient psychiatric admission versus discharge to the community. Group home patients, can they go back, or do they need to move to a different care setting? Which patients can you safely discharge home? Empath and other observational units, is it possible to hold patients there until a spot in the community becomes available? So really, you can see the connection here. Really being aware of all the resources in the community is super important. And then continuing to build those partnerships with community resources, mental health resources, where these are available. I'm going to go one more, and then I want to hear from the panel one more time. So we choose appropriate level of care, and then warm handoffs are critical. I think everybody knows what those are. We don't have to say a lot about it, but that is just so important and so easy to miss that step of giving all the important right information. And standardized questions can help with kind of intra and inter-organizational communication, right? So we have learned in a lot of our work groups that everybody has a way of doing things. And sometimes that means it all gets done differently within the same organization or between organizations. And so standardizing things so they don't get missed can be super helpful. So I am going to pause here. And Laura, I'm going to ask for any feedback on this kind of level of care and disposition to the home or somewhere else.
So community resources are key for discharge of these patients. Duluth has a pretty active team that looks at these environments, and just to make sure that we have the resources available for the patients that with mental health concerns that need those resources. We have a crisis response team, a behavioral health community service, Birch Tree, law enforcement, our hospitals, both of our hospitals within our city. All of these members collaborate to just look at the resources and ensure that we're putting the right pieces in place and have the right environments and transitions of care for the patients that need them.
Thanks, Laura. Lou?
Well, I would say two things. One is the emergency department is very useful at getting a snapshot in time. We see the patient in the moment, we make an impression, and we make a conclusion about their needs. One of the things we've seen in the empath service is we get to see it more as a video than as a snapshot. We get to see the person over hours, sometimes over a day. And in that time, we see them adapting to their environment differently, and we can make different disposition decisions. The ED, the same ED was admitting about 38% of patients with mental health complaints prior to the empath. Today, we're at 17%. And it's not a different population of patients, it's a different point in time of deciding which disposition is most appropriate. The other thing that we've started is a transition clinic. What we were finding is that the delay between discharge from the ED and their first appointment, that time was critical. Even if they left with an appointment, it might be days or even weeks out, and that time was very difficult for some patients. So we've started a transition clinic, which allows us to see them the same day and each day between, or as often as necessary, to help bridge, to allow them both to stay motivated for care and reduce sort of the periodic escalations in crisis that may occur before they're able to start care. So both of those have been really valuable in terms of the disposition planning.
Thanks, Lou. So I'm going to ask those who have joined us today, if you have any questions, please type them into the Q&A. Laura and Lou are experts here and happy to address anything more specifically. In the interim, while I give you a chance to do that, Laura and Lou, if there are like one or two tidbits that have just been so helpful that you want the participants to walk away with, can I ask you to share those? So Laura, can I start with you?
Certainly, I think that really training your team and having your team prepared for caring for patients, anticipating, is giving them the tools that they need to better serve these patients and really get the patients to the care that they need and safely for everybody that's involved.
Lou?
I think The most important thing I would say in terms of reducing aggressions and staff injury, et cetera, is giving patients enough room to de-escalate with help, but also to use some of their own resources, internal resources, to help themselves de-escalate. And where we get into conflict with those is where we seem to increase the amount of aggression, the amount of staff injury, the amount of patient injury, et cetera. That we need to give room, and then also having an environment that sees people over time as opposed to in the moment, to assess what their needs are and how best to serve them once we've cleared them medically, certainly.
So I have a question here. Can you tell us more about your transition clinic? Who staffs this and how many people work in the clinic? Do you rotate outpatient staff or have hired staff into these positions?
Sure. So we use licensed mental health professionals, which are typically LICSWs or comparable psychologists, et cetera. We staff the program from 8 a.m. to 10:30 p.m. 7 days a week, because people don't always fit into the 9 to 5 Monday through Friday schedule. We've also just hired a nurse practitioner who will be able to help with medications and adjusting medications during that transition period. And what we found is it's not a substitute for care. It's not our goal to say this becomes your medication provider or this becomes your therapist, but in fact simply provides a bridge, whether that's days or weeks.
Thanks, Lou. All right, I want to just take a moment to say thank you to our participants for joining us today. Thank you to Laura and Lou so much for your expertise, for your involvement and leadership in the work group, and then for joining us here today. I'm very grateful for this work. I encourage everybody to please go look at these ED standards. Particularly the agitation is more of a toolkit. So there's questions within so that you can answer about your organization. It's really designed to walk you through the process. And we hope that would be helpful. And we would love feedback on it as well. So please look at it, reach out to ICSI, to me or anybody at ICSI for any questions. And don't forget about our suicide webinar in September. We will send out more information shortly about that. So thank you, everybody. Have a good weekend, and we hope to see you all soon.